This program is brought to you by Emory University.
All right. Good morning, everyone. Welcome to Grand Rounds. Today we have another one of our own faculty members, Dr. Dan Sarescu, who has generously decided to give us the part 3 of his lecture series. He did the first 2 last year, if you remember, and those are recorded and available on YouTube and on the Emory channel. Dr. Sarescu went to medical school in Romania, did his internal medicine residency at Albert Einstein, and then did his cardiology fellowship within the basic science cardiovascular track here at Emory. He's an active member in many national organizations and serves as a manuscript reviewer for many of the top tier journals in cardiology related to heart failure. More recently, Dr. Sarescu received the prestigious James Steiner Award for Outstanding Service for Patient Care at Midtown. And for those of us who've had the pleasure of rounding with Dr. Sarescu on the heart failure service, I just remember, Dan, rescue Sarescu, and how you would talk to patients and all the wonderful things that you've done over the years there at Midtown. I'm going to turn it over to you. Today, you're going to talk to us about GLP-1 receptor agonists for obesity-associated cardiovascular disease.
Thank you, Pooja. I'm grateful and delighted to, and really thank you for your kind introduction. But so today, I'll try to see if I can complete with part 3, really, of this lecture series that I started last year. If you remember, the first one was the role of fructose and particular sugars in development of cardiovascular disease. The second one was living clinical trials for various diets, and I touched some base about the role of ultra-processed food, which I'm going to expand further on this one, and then talk about how really is the ultra-processed food that drives the obesity and coronary disease epidemic. And although it might surprise, I like to give a more integrated approach about actually that the basis of the cellular basis of biological basis of everything is happening, whether it's health or disease, is actually our mitochondria as a biological clock in health and lifespan. And I'm going to try to convince you that ultra-processed food, by interacting and driving the mitochondria, are the one which are majority cause majority of the disease. Second part, I'll talk about the role of GLP-1 receptor agonists, namely semaglutide and Tirzepitide for secondary prevention. And the third part, not sure if I'm going to be able to get into that, but for those who are interested, I do have an extensive 4-hour lecture that's posted on YouTube and that I gave in June, which is both for patients and healthcare professionals, where I go in extreme details how to do it with lifestyle changes. But to the big picture is here. We've known now for over 20 years from the InterHeart study that there are 9 risk factors that account for about 90% of all heart attacks. And if you look careful, more or less 8 out of 9 are related to diets. And if we were to look also, one could consider psychosocial index is also heavily influenced by the diet. Now, if we look on the cancer side, well, maybe surprised, the oncologists kind of look at the same risk factors, except you also have the ultraviolet radiation. What they all have in common is this concept called oxidative stress. I'm going to try to, what this emphasizes the fact that contrary to 50 years worth of basic science research, really we only have about 10% of the cardiovascular disease or cancer that is explained just by genetics, which will predispose you to disease. However, 90% is actually related to epigenetic changes. So what it is a concept that Dr. Dean Jones from Emory actually developed, that exposome is all exposure in our lifetime from conception, which includes lifestyle, stress, and our biological responses to exposure, which cause mutation, rapid genetic changes. And that's Dr. Dean Jones is a biochemist, and now it's currently in the division of pulmonary disease at Emory University. And the other person who has developed the mitochondria is the father and grandfather mitochondrial actually genetics. That's Dr. Douglas Wallace, who was here at Emory for about 20 years, and now is the University of Pennsylvania. So the big, if you were to look at the big picture, really the single most important risk factor is actually age. Is the greatest risk factor for all chronic disease, including heart disease. For example, right now I'm in my mid-50s. My risk of coronary disease or cancer is about 100-fold higher. This is log scale, by the way, compared to when I was in my 20s. And the same for every other chronic disease. So when we get old, we also get chronic diseases. So what do they have in common? They come together. There's also, we have evidence for the opposite. If you do get a chronic disease in a single organ, it shortens your lifespan in all organs. For example, for heart, for every year somebody lives with heart failure or heart disease, they live a month shorter. And the single most important, impact seems to be actually lung disease, which is more. So, but what's fascinating, every chronic disease and aging are actually associated and come together with, if I were to put together pre-diabetes and diabetes together, it's about 80% of everybody who either is old currently or has got cardiovascular disease, they get up to, it's prevalent. So this come together too. And if we were to look from genetic perspective, Alzheimer's, TTR amyloid, for example, which Dr. Bhatt is very passionate about, they are genetic determined, right? The question is, why do they develop only when we get old? Why does it wait for 70 years for that to develop? And what we actually have some direction of an answer for a spontaneous and unfortunate situation with patients with Down syndrome who actually have on their extra chromosome 21, they actually have extra transcription factor enzymes that actually contribute to their disease. One of them being, for example, the copper zinc S-superoxide dismutase, which its job is to inactivate superoxide in cytosol and convert it to hydrogen peroxide, which paradoxically actually increases the oxidative stress. The second thing happens with these patients with Down syndrome, actually they get their incidence of, they get early diabetes, type 2 diabetes. They get the oxidative stress, starts at age 20, 30, which for somebody aging normal starts in the 50s or 60s. And they also get amyloid deposition early and eventually Alzheimer, which is 20 years earlier than before. And turns out this extra chromosome 21 has actually some transcription factors that inhibit actually the mitochondrial biogenesis. And it's part of the oxidative stress. So what I'm trying to make a case here that Down syndrome is a natural, unfortunate disease. It's a good model of a mitochondrial disease with high oxidative stress. And what we're trying to put together is what we have at the intersection between chronic diseases and actually aging is actually mitochondrial dysfunction. So now if we go back to cardiovascular disease, we have this piecemeal approach where we study, we're trying to look at the elephant and we study different parts of the elephant and we say, okay, what causes cardiovascular disease? Is genetic, is diabetes, is high blood pressure, is stress, it's LDL cholesterol, it's obesity. Unfortunately, those are small biases that unless we can be able to integrate and put it as a whole, we may actually miss the big picture. And that's why often we're disappointed with the conclusion we can extrapolate. The same with cellular and genetic causes of trying to study the basic science level. For example, it's like there's a major traffic jam, and then we try to study the internal combustion engine in all cars, trying to figure out why there's a traffic jam. That's not going to help. So we need to combine those two. And I'm going to present here a more globally integrated perspective of human health of disease. And I'm going to state the dogma that mitochondria are our biological clock that determine our fate. And this really is inspired from research from Dr. Nick Lane, who is at University of London College in England, who is an evolutionary biochemistry, doesn't just study mitochondria in biochemistry as of today. He's actually interested from evolutionary perspective. How did we get, and he's asking the question, why? And what he found is that actually, and he gave this nice analogy in one of his books, think of mitochondria as a big Tesla battery that is supposed to last the moment you were conceived for about 500,000 miles. And batteries they can keep recharging, and that's how mitochondria regenerate every 2 or 3 weeks. But ever so, each time they divide, they become less perfect than there was the original one where we were conceived. The second rule of battery is that it's only so many charges you can have. At one point, mitochondrial structure will change to the point that eventually they will collapse. So this principle actually may allow us that really, if you were to actually look at and put what are the mitochondria do, they're actually a big battery, big capacitor. It's actually, if you were to calculate the amount of electric charge across a 4 nanometers inner mitochondrial membrane, that's equivalent of electric bulb. It's a huge capacitor. So I'm going to propose to you that this battery is supposed to last us for 120 years old. It's heavily, we can go through it fast or slow, depending and it takes our lifespan, health span, depending how risk factors influence this. And to quote him, if life is nothing but an electron looking for a place to rest, death is nothing but that electron come to rest. This is from his book, Vital Question. So I'm going to show about 4 slides of mitochondria, which really updates briefly about 9 Nobel Prizes worth of research, but it's important and essential to understand 3 laws of mitochondrial biology and function that drive everything that's processed from our environment in our cells. One is in a basic nutshell, mitochondria is basically our cell oven, where all the food and oxygen get burned to replenish our cell structure and provide energy and heat. So we're homotherms. And in a nutshell, what mitochondria likes to burn is actually glucose, saturated fats, and rarely proteins, unless we are starving, although cancer cells can use glutamine. We expose it to oxygen, in a nutshell, glucose or fatty acids are carbon-based structure. It could be 6 and hydrogen. The carbon is extracted in the Krebs cycle and goes back in the cytosol to actually derive amino acids, DNA, RNA, lipids, and that's what we call carbon-based cell structure for regular growth and repair. But what's important is the other side of the coin. The hydrogen part is the one that's split from the electron. The electron has the energy. This is split across an impermeable inner mitochondrial membrane, which is 4 nanometers thick, and creates this big proton gradient across the mitochondrial membrane, which then drives the ATP synthesis through ATP synthetase. And the electron keep passing on the electron transport chain to do that. So that's in a nutshell the simplified version. But what's more important is that this the mitochondrial redox potential, it's a homeostatic variable. It has to be clamped. Capacitor of this battery has to be clamped and functions between minus 150 minus 200 millivolts. If we have more than less than minus 150 millivolts, the mitochondria will destroy the cell. The message is you're no longer good to make ATP. You need to die. And in the other way around, if we have too much abundance of substrate, such as fructose, glucose, alcohol, or we don't use the ATP, like in sedentary or in aging, then aging per se can also affect this electron transport chain, because with each division of the mitochondria every 2 to 3 weeks, the subsequent generation has actually introduces mutations, and potential for mutation is not as good as the original. So basically, normally we have very low, most of the electrons will be converted into energy, such as ATP. Less than 2% of this electron will actually go to bind directly to oxygen to create superoxide and free radicals. However, under abundance of energy and under chemicals that actually can direct away the electron transport chain from ATP production, but towards actually more storage and carbon-based production, then we actually have accumulation of free radicals as a mechanism of escape. But also these free radicals are actually signaling molecules. The mitochondria communicates with the cytosol, so they're in sync in terms of what they're planning to do through these free radicals. Now, what happens is if we have abundance of this substrate, not only that we create more of this superoxide and free radicals, and energy is shunted away from ATP production. But then Krebs cycle backs up and starts to go in reverse. And then we start to basically acetyl-CoA goes out of the cytosol, and then it's going to be converted towards storage or growth. That's the signal. Mitochondria says, well, if my potential is over minus 200 millivolts, I got too much substrate, it's time to grow. And growth as a child or in pregnancy, it's natural, healthy. But if we are over 25 years old, the growth is just storage, is abnormal. So this will actually promote mitochondria to stall divide. They need to deal with more substrate they have. Mitochondria then drives the cell growth, the fast storage. And this, we can be at this stage for 10, 20, 30, 40 years. And this is the stage at the higher oxidative stress, cellular stress, that drives the transcription machinery. That's a substrate for chronic disease, metabolic syndrome, diabetes. Another thing that comes, mitochondria are all bacteria. They've been symbiotically acquired inside the eukaryotic cell. One of the things that bacteria have to fight with viruses. So the moment we have this kind of growth signal, actually triggers an inflammatory signal from the mitochondria towards the rest of the cell. And the first actually pathway that gets activated in each and every cell is the angiotensin converting enzyme, angiotensin system. Why? Angiotensin 2 is also growth factor, just like insulin. All right. And meanwhile, unfortunately, the body will fight with the opposite, particularly the fat cells. We're going to try to reach a new balance by creating an anti-inflammatory response. That would be the ACE2 receptor pathway that goes up. And guess what? That's also a receptor for COVID or various viruses and bacteria. And for example, COVID in particular has a microRNA that actually targets the electron transport chain and can cause acute fulminal failure, such myocarditis or ARDS if it's widespread. So if a cell which is functioning already in chronic metabolic state with higher oxidative stress, is way more predisposed to actually undergo apoptosis. So this is what I'm proposing to you in a nutshell, the basis of our chronic disease and aging. Mitochondria can be engine for life if we are healthy, or can be engine for death. And at the end of the day, I'm trying to propose to you that it doesn't matter what experts say. All it matters is what mitochondria considers food or not. And we're going to go over that. Now, the first principle, as I mentioned, that drives the mitochondria is that requirement to maintain the proton gradient and the battery between 150 and minus 200 millivolts. The second requirement is that to maintain that, the Krebs cycle and the electron transport chain work together. See, Krebs cycle provides the NADH, and they work like in sequence, like a bike chain on a wheels. And if you pay attention here, the another thing that happens is when the energy is extracted, it's passed on in the electron transport chain as electrons, one electron at a time. So the system, it's saturated and depends on one. That is important because this way we can extract infinite amount of energy from anything we eat, but at the same time, it can predispose us to have electrons that have not been used and not pass on to the energy, and they will be actually passed on directly to oxygen to create superoxide and free radicals. So if you can see that in a state where we have low demand, like sedentary, for example, at night when we sleep, the ATP goes up. Actually, that inhibits this electron transport chain. Or if we can have an oversupply, such as a lot of glucose, starches, calorie intake, fatty acids, you can see how the system then starts to drive direct reduction of oxygen, molecular oxygen from superoxide, because the electron transport chain is leaky and it's maxed out into what we can transport. That leads to chronic elevation of radioactive oxygen species. Another way of looking at the cell and the mitochondria is that really the cells function at a given state. They can function in low oxidative stress. Here, what you see here on the left, where it's healthy, that usually the free radicals, the hydrogen peroxides in a nanomolar range, can function in this proliferative inflammatory state. Chronic disease, typical to chronic disease and type 2 diabetes. This is usually 100 nanomolars. Or if the oxidative stress goes too high up in the macromolar range, that can trigger apoptosis, or that's part of actually evolution towards cancer. So what I'm trying to say is that each time we have either increased supply or reduced demand, there is a tendency for this free radical production, but also Krebs cycle backup, which actually those are all chemicals that reprogram epigenetically the cell towards fat storage, proliferation, and apoptosis. And not all nutrients are the same when it comes. For example, mitochondria burns glucose and fatty acids. That's the preferential substrate, but it does not burn fructose, linoleic acid, alcohol. Fructose is in sugar, linoleic acid is in the polyunsaturated fatty acid from vegetable and alcohol. These compounds, actually, what they do, they drive the signaling and disrupt the electron transport chain towards actually storage and fatty acid accumulation. So they're not important through their calorie, but actually they're important by signaling the mitochondria to change towards growth storage phenotype. And ideally, the only way we can actually switch back to this lower state, and we need to reduce the load of free radicals that are produced by this and get back to one electron change. The only way we do if we actually reduce either calorie intake and combine with reducing the signaling molecules that actually direct the message the wrong way. And of course, the best actually for the mitochondria health is actually exercise and just taking a break from food, fasting. So the third principle of mitochondrial biology is that mitochondria, we acquired them about 2.2 billion years ago into an eukaryotic cell to produce ATP that allows our cells to have 10,000 times more ATP than our regular bacteria. And that allows the actual eukaryotic cells to associate. And once we increase the oxygen Earth atmosphere in the Precambrian area, that's when we start to see mammals appearing. We're able to actually associate cells into organs. They're specialized, differentiate part of the bigger organism. In other words, mitochondria drive differentiation and specialization of a certain organ to do a certain function. And all you need to vary the amount of mitochondrial oxidate phosphorylation per cell. So we have anywhere between, for example, sperm cells has 10 to 100 mitochondria, while the cardiac myocytes has up to 100,000 mitochondria per cell, and that allows their specializing. But at the same time, mitochondria also turns out some evidence that contributes to not only to us organizing from cells to organs and organs, but also drives our human relationship. That's some recent research from Dr. Wallace laboratory. So mitochondria health are actually, they keep regenerating every 2 or 3 weeks. They're extremely dynamic. They can fuse into tubes. But however, exposures to toxins such as fructose, oxidized omega-6 fatty acids, alcohol, smoking, toxic air, sedentary stress, that actually causes the mitochondria, some of these in advanced stages of oxidative stress, mitochondrial DNA to be released. And it's fascinating, mitochondria that actually from one cell, from one organ, goes into the bloodstream and communicates with the cells from other organs. And that triggers free radicals production in other cells. It's like the mitochondria in one organ try to put in sync all the other organs, including the brain. And we know we have to tell them, well, we got abundance of substrate, we need to grow. By the way, if you go out foraging, you might be exposed to infections and attackers. I'm going to also activate the inflammatory system. And that's actually the stimulus, I believe, for neurohormone activation that precedes almost every chronic illness. In exchange, why? That neurohormonal system is actually growth factors. Hey, it's part of the same signal that we send to all organs. We got to grow. And unfortunately, we can't grow as an adult. That activates insulin. Insulin is also a growth factor, not just a glucose storing agent. And we get uncoupling between the growth factor function and the glycemic function, and the cycle perpetuates. So this is a hypothesis that I put there. And then, of course, with our medicines, we can do that by cutting off the ultra-processed food that's a source of this. We can improve this, or to change back the phenotype, or the only agent they showed actually to improve mortality and MACE in cardiovascular disease are also the agents that one or another seem to disrupt the cellular metabolism and mitochondrial function and reset it back to normal oxidate phosphorylation. And I'm talking about heart failure agonists, beta-1 receptor antagonists, SGLT2 inhibitor, Mounjaro receptor antagonist, but also more recently, it's likely the GLP-1 receptor antagonist. That's how they work, by normalizing the metabolism and proper response to insulin, cellular insulin. So the last rule I'm going to present to you is that depending on the level of the oxidative stress, you see, 1,000 mitochondria has over 1,000 proteins, but only 13 are actually encoded in the mitochondrial genome. The rest are encoded in the nuclear genome. If anything happens, if you have increased oxidative stress and your mitochondria are going to function in a certain state, each comes with a certain epigenetic regulation. So normally, staying on the low oxidative stress type in the nanomolar range of hydrogen peroxide in the cell, and healthy and younger and take our time to die, so to speak, that's actually associated with these transcription factors. So these transcription factors are the mediator that put in sync the protein synthesis in the mitochondria with the one in the nucleus, in the cell, in the cytosol. And that's when we get differentiated, cells, like in muscles, but also on inflammatory, your immune system and macrophage in particular use the M2 macrophages, use the oxidative phosphorylation and the Tregs, which fight against inflammation in a steady state. Now, once we get exposed to chronic dose-dependent toxins, they tend to come and increase, not only that they force the mitochondria to produce free radicals, but themselves generate free radicals in cytosol. Then the cell starts to move into this state where we have increased oxidative stress. Remember, the free radicals are like the dollar coin for the cell. The mitochondria communicate with the rest of the cell and regulate and sync the nuclear transcription of genes and expression proteins with the mitochondrial one. Why? If I have excessive substrate, I need more mitochondria. How am I going to get more mitochondria? Well, sure, mitochondria can produce 30 new proteins, but what about the other 900? The nuclear gene expression has to be activated, has to go to where it needs to be. So this requirement for sync actually changes immediately. As soon as you have increased oxidative stress, the cell moves there. We're going to have completely different transcription factors that drive that. And in heart failure, we have hypertrophy, proliferation for those cells to proliferate, but they also switch to glycolysis. Now mitochondria are no longer producing ATP. They're in charge mostly to produce carbon substrate for the cell to grow. And then in heart failure, we have a fetal change to fetal cardiac myocyte. In coronary disease, we have the smooth muscle cells that change to synthetic smooth muscle phenotype. And guess what? Our immune system, the T cells, switch from a regular Tregs to CD4 T IL-17 cells that are being incriminated actually by research from Dr. Dave Harrison in hypertension. So we switch to our primary inflammatory stage. And this is designed to stay there for 10, 20, 30 years, as long as stress is there, try to adapt and reset. Unfortunately, we change our cells from a quiescent differentiated phenotype that does what the organ is supposed to do to a storage phenotype, which I call it metabolic disease, oxidative pro-inflammatory aging phenotype. And then, of course, if this continues, and for certain cells who are exposed more than others, we get a certain acute inflammation, then each organ starts to lose cells little by little. They could be discrete or can be a mass if you have like septic shock or depending what infection is happening. And then we still have a completely different transcription factor activation. This time, this kind of oxidative stress leads to either apoptosis or proliferation. It's also the source of DNA, both mitochondrial and nuclear DNA mutation. And if some of the cells we have failed, apoptosis can either cause senescence or with subsequent organ dysfunction or can cause cancer. So I want you to understand this as a process that we're going to work with. But if you want to know more, really, this was articulated very well in this article by Dr. Robert Lustig, Obesogen, a Unifying Theory for Global Rise in Obesity. Now, epigenetics, in other words, mitochondria determine the epigenetics. So here is about epigenetics. We have evidence that if you feed in rats, in mice, and some evidence in humans, if a pregnant female is exposed to a lot of fructose in their pregnancy, it turns on genes like angiotensin to anything for the next 3 generations the offsprings will have hypertension. So that's epigenetic, another way of epigenetic regulation. They can be transmitted from generation to generation. And we always talk about nature versus nurture. Really, nature, the genes allow us a certain predisposition, but the fate of the organism depends on the organismal exposure and sometimes the prior ancestors' exposure. So in a nutshell, 10% of chronic disease, it is determined, it is genetics. 90% of chronic disease, it's actually exposure, like Dr. Dean Jones' exposome epigenetic that dictates the organismal fate. And why am I insisting on that? It's very simple. If it's genes, there's nothing you can do about it. Forget about it. You tell that to any patient, they're not going to do anything about it. But if it's the environment and something we can work with, but with education, that can actually change. And at the end, mitochondria drive and constrain our cellular phenotype response to exposome. I'm quoting Dean Jones again, and I'm going to add with research from Dr. Nick Lane that mitochondria and actual biology are constrained by the biochemistry, energy and metabolic flux, and the physics at the end, protogradient, and the idea that mitochondria are a big battery. So having said that, I'm going to basically submit to you that a unifying hypothesis that really the whole basis of cellular chronic diseases is the cells are sick, they change their phenotype, and they get insulin resistance because mitochondria changes their phenotype and has to drive the nuclear transcription and expression. And that, although they love in a day-to-day basis to use glucose and fatty acid, that's pretty much what's burned. There are other toxins in our food or in our environment that actually blocks this mitochondrial electron transport chain by working well and drives through increased free radical production towards storage and substrate deposition. And basically, they are also themselves, they create free radicals in the cytosol. So it doesn't matter where the oxidative stress comes from. If it's from mitochondria or it comes from cytosol, the genetic expression will be in sync both in mitochondria and the rest of the cell. And that will change, our phenotype towards storage and growth. And yes, if we are children, that's wonderful because we got ways to grow. If we are pregnant, that's wonderful. We need that. But short of those two natural states of insulin resistance and storage and growth, everything else starts with mitochondrial dysfunction, which leads actually cellular insulin resistance. It's like mitochondria say, hey, you can't give me more food until I deal with this. So, and I need not the insulin ability to introduce more glucose in the cell. I need the insulin ability to stimulate our growth. The same with angiotensin too. And with time, this mitochondria, where they try to divide, they can actually undergo genetic mutations. And this is, I think, the substrate for all the chronic illnesses we're going through. So now going to things that are easy for us to understand, I would say, and I'm going to submit to you, that ultra-processed food is the greatest modifiable risk for chronic disease and accelerated aging, all right? And we know it's a problem because we moved from less than 10% in the 50s. Now we're up to 62% of all calories intake on a daily basis, at least in the United States. In Great Britain, is very close. Teenagers are up to 70%, unfortunately, and obviously 90% of sugars in the diet comes from that. And I'm going to propose to you that if we are able to modify that, we can actually improve not only our lifespan, but also health span. And we have evidence already this is reducing the lifespan, at least of our kids, and causing diseases because diabetes type 2 has shifted from 70s, which was a disease of old people, really less than 1% of type 2 diabetes was somebody younger than 65. Now we are, the majority is actually in somebody who's younger than 65, half of them not being aware. And we also have a new condition in children we never had. Turns out type 2 diabetes always comes with fatty liver and plus minus obesity. And kids don't drink alcohol to cause fatty liver. Their problem is sugar, fructose, vegetables, and ultra-processed food. And they're getting older, unfortunately, and not live that long. It's actually first time we have evidence now that in the last 3 years, it's first time where actually in US, the lifespan is going down compared to 5-10 years ago. So to call like Dr. Lustig, what is food? Food is what happens between mouth and gut. nutrition, what's in the gut, extracting the essential chemicals that are used by substrate. And the third part, what's inside the cell, metabolic health, is what actually happens in the mitochondria. And that will happen with normal home cooked food that happened for over 10,000, for 6 million years in our evolution until about 50 years ago. Now we have ultra processed food that come with fructose, trans fats, heavy vegetable alcohol. They're actually poisons. They actually block and disrupt mitochondria to drive it, and they're sending a signal for storage. Fast storage, abnormal growth, inflammation, oxidative stress, and that contributes to our chronic progression towards disease and aging. So to me, the message that I send my patients is like, if you eat that, although you think that's food, that's actually not food, because that's not what mitochondria thinks. Why is it ultra processing, and what is ultra processing? Why do we like so much? So Dr. Carlos Monteiro in Brazil was the first to come up with this concept, and I like it. We knew a long time ago, oh, junk food is bad for you, but this is a little different. He was able to articulate, create 4 food groups that allow us to also analyze from epidemiology perspective the association between these kind of foods and disease. And so I'll show you what happens when we actually try to take some kale and convert it into kale chips. So what do? We take the kale, we add sugar, salt, and vegetable oils. We really add a lot of that because we need to heat, and we have to heat and dry conditions at 450 degrees to create that crispy nature of the chips that they will last. We also, because we disrupted the food matrix, the food will have no taste unless we add food additives, flavor enhancers to fool us, emulsifiers, preservatives, and sweeteners. And really, each and every one of these actually have been associated with metabolic disease, leaky gut, inflammation, you name it. And why do they have to do that? Is because they want us to buy more, and they are for taste, smell, texture, palatability, addiction, preservation. These actually, the principles of this have been developed over 50 years ago by the food industry, and it's called bliss point. They know exactly what, and they know how to test it, and they will keep working on a product until it gets to that bliss point that we just have the best chance to get addicted. So that's what creates ultra processed food, and now we have kale chips. But in the process, when we disrupt that food matrix, you lose, not only that we get this all extra stuff, but it also destroys the natural antioxidants. And this is not, when we say these are carbs and fats, they're actually oxidized protein. When you heat them up in dry condition, those carbs and fat interact with each other, interact with the protein and oxidize them. And because of that, actually, our brain does not see it as food. That's why we get actually hungry and have increased appetites, and we get also metabolic disease. So as a consequence, now we know that about 50% of adults are addicted to it, about 12% of children. So, you say, well, how do we know this? Look, let's read the label. I want to show you what happens. So if I were to look at the total fat here on the label, I subtract the saturated fat. Why? That's used my mitochondria. Now that is not important, but it doesn't get oxidized. And then I can see the polyunsaturated fat as it comes actually from seeds. And the same with the sugar. So I have here in this bag of chips, 25 grams of total fat, from which saturated fat is 3 grams. If I subtract, so you see it was not on the label what matters. If I subtract my saturated fat from total fat, I get the polyunsaturated fat, 25 minus 3, 22 grams. Sure, there are some monounsaturated if it's done with olive oil, avocado oil. That might have some, but most of the time it's a minor contribution because it costs more. So I got 22 grams. So I tell my patients, I convert that in teaspoons. I divide, 1 teaspoon has 4 grams. So I divide 22 by 4. We got 5 teaspoons of vegetable oil in these chips, which they, otherwise they seem to be fine because they are from kale. And I got also, when it comes to carbs, total carbs minus 7 grams, of fiber. I got 9 grams, 2 teaspoons. Now let's compare with the original kale. Look at this. We moved from total fat 0.8 grams, which most of it, and some of it was polyunsaturated, just healthy, unoxidized fat. We moved to 25 grams. So we have a 20-something fold increase in this. And yes, there is some saturated fat, but majority of this is actually polyunsaturated fat, omega-6s, and they're oxidized. This is food that's oxidized and contributes to oxidative stress. So or I'm trying to make a case with a long-term exposure from toxin from ultra-processed food cause mitochondrial reprogramming and chronic diseases. Our Western diet is highly rich in not only saturated fat, which has been placed the blame on for the last 50 years, but actually it's omega-6 vegetable oils, fructose from sugar, salt, but also it's deprived of fiber because it's been destroyed in the process, particularly even at home. You take, we do juicing and smoothing and kills the fiber, but also is low on omega-3s, which are natural anti-inflammatory substance, antioxidants. And about 20% of disease is actually caused by those additives that we add. There is BPA, phthalates, and parabens, preservatives, plasticizers. These have been incriminated to be actually endocrine disruptors, and they're estrogen looking like substances. They're being incriminated and associated with all kinds of issues. Their presence in anything anywhere from plastic to chewing gum. Pesticides we know is bad. Hydrogenated oil is nothing, or partial hydrogen is nothing but pre-trans fat. All it takes is just heat it up and you get trans fats and cause mitochondrial damage. Carrageen, sweeteners, we add them for taste. Carrageen, carboxycellulose, those are emulsifiers that cause leaky gut and gut inflammation. And the MSG red and yellow are actually stimulate glutamate, and they're there for actually addiction and to eat more. And it doesn't matter, there are 0 calories. So I add all this together. I call them the food additives, HFpEFs, flavor enhancer, emulsifier, preservative, sweeteners. It allows you to read on the label and just go for that. You don't need to name the name. You just need to see if it says for flavor enhancing, for emulsifier, for preservative. So for last 50 years, we operated in cardiovascular disease based on a dogma that saturated fat causes cardiovascular disease. Unfortunately, we know that it doesn't work. If it were to work, we would stop talking about cardiovascular disease. And I'm sorry, that's number one. And number two is there is a nice review paper in JACC, which is actually one of the highest cited in that year papers in 2020, that look in a critical manner. And really, if you were to look at all studies, not just select and pick and choose depending which bias you have, there is actually no evidence that necessary meat and saturated fat increase cardiovascular risk or diabetes. And I'm not saying they don't contribute. I'm just saying per se, in the absence of the other guys, don't. And more recently, actually, there's a reevaluation of the whole traditional diet hypothesis. There are 2 studies, Minnesota coronary experiment, which was actually a prospective randomized study that was started in the 70s by Dr. Ansel Keys. And also there's a Sydney heart study. They put them all together. Basically, not only they didn't show that it prevented the reduced mortality, but also, although if you replace the saturated fat from meat with vegetable oil, in particular linoleic acid at equivalent about 12%, you indeed drop the LDL cholesterol by 30, or your total cholesterol by 30 milligrams, but for each of those, you increase by 22% increase of mortality. So yes, we can use cholesterol as a marker, but not necessarily disease will correlate with what your total cholesterol or your LDL. So this sets us back and start to think, well, we should have probably an alternative hypothesis. Wait a minute, we've done that, what they asked us to do. We're sicker than ever. What would be an alternative hypothesis? And, many, and not just me, have hypothesized this, particularly Dr. Lustig, that sugar, in particular fructose, seed-based vegetable oils from polyunsaturated fatty acids, cause obesity, type 2 diabetes, and coronary disease. And again, that's on top of the saturated fat because we can never remove that and not have it. Remember, these guys don't get burned into the mitochondria to make ATP. They drive the use of saturated fats and the use of glucose towards storage. And that's what I'm proposing here. There is the ultra-processed foods are toxic, not only because you have chemicals that completely drive away the mitochondrial metabolism away from ATP, but towards storage and growth. But also you have food additives that do the same thing and they get us addicted. And probably the single most important mechanism of how they work is this part, the acrylamide, acrolein, actually the aldehyde. And I'm going to show you. So keep that in mind. Why? Because per se, that's enough to reset the cellular phenotype towards an oxidative stress, and then mitochondrial part will follow. So 3 studies that I'm going to show you quickly. One is Dr. Kevin Hall. I showed you this last time. Took about 40 healthy humans in their 20s, 30s. They randomized them to having the same proportion of macronutrients, fats, proteins, and carbs, but some of them will come from ultra processed food, some of them will come from and the other version will be just homemade, home cooked. And within 2 weeks, what he notices that, and of course, people were encouraged to eat at libitum, but also they were doing daily 45 minutes stationary bike exercise. So everybody got the same exercise. And towards his surprise, the people on the ultra processed food gained 1 pound a week, so 2 pounds at the end of the 2 weeks. But look what happened to the other ones. They actually lost 2 pounds. There's nothing mentioned about that. So at the end, there was actually a 4 pounds difference within 2 weeks, which suggests that the ones who were randomized and they were on the healthy diet, the same macronutrients percent, probably they were eating a lot of ultra processed when they were switched to healthier version. And of course, this association, eating ultra processed food, even if you have the same macronutrient structure and percent, you eat more. There's no doubt. Your fat goes up. But also, when you look at the biochemical level, you have increased insulin resistance, leptin resistance, increased ghrelin, which makes you eat more, and you reduce the satiety hormone, which is PII. And this is the setup. So, but what's more important, he also measured the basal metabolic rate before and after. And it was fascinating. The one who gained weight had an average 7.8% increase in metabolic rate, based on the other one went down by 7.5%. Why? These are of all the mitochondrial function, in particular in the skeletal muscles. So that if your basal rate goes up, your mitochondrial function is burning faster. And at least in my hypothesis, you live shorter because you run faster through those guys. So bottom line is, this is some evidence that ultra processed food is actually a majority risk factor at the mitochondrial level that drives this process. Conclusion from Dr. Hall was that these results contribute to a growing body of literature in the ultra-processed food may be an important contributor to food choice and intake. So obviously his interest was into what's happening to the brain part. However, I think it's what happens at the cellular level that is important, and these are the main drivers. Now, we also have the opposite experiment where healthy humans were exposed to a calorie-restricted diet for 2 years, and then they measure similar outcomes in 2 years later. They were actually able to lose about 10% of their body weight. So it's kind of what Ozempic will do, but without Ozempic. And guess what? We got exactly opposite results. Your weight went down, the basal metabolic rate went down, the thyroid, insulin, and leptin resistance have improved, and the oxidative stress went down. So we can see how we can shift by changing the individual cellular mitochondrial function, basal metabolic rate being a surrogate for that, in the impact into this. So
and
last but not least,
now it's 10 minutes left total.
So last but not least, I'm going to stop here after this, and I'll go for the semaglutide. But this is important. So earlier this year, this is a Cochrane review that was published on the impact of ultra-processed food exposure and adverse outcome effects. And they show that increasing in ultra-processed food has been associated with increased risk of heart disease, mortality, type 2 diabetes, mental disorder, obesity, sleep disorder, fatty liver, and cancer. So we have also clinical epidemiologic evidence of this correlation. Connection between obesity and coronary disease, we actually know that currently in this country, obesity starts as metabolic syndrome, insulin resistance. We used to be the 88% of us were not healthy, metabolic healthy. Now we are up to 92%, and we call that metabolic syndrome. Metabolic syndrome, though, is important because although obesity per se gives you a 2 to 3-fold increased risk for cardiovascular death, insulin resistance and metabolic syndrome gives us actually twice more, 6-fold. And when it comes to that, and we accumulate fat based on the MRI data, and it matters where the fat goes. So it's the visceral fat, particularly the one in the liver, that drives the disease. And the fatty liver is associated not only with negative outcomes from the liver perspective, but also has increased to about 45% in adults in this country, 25% in children, but also it's the first stage actually of type 2 diabetes. It's a requirement for type 2 diabetes often. Some of it may start from genetic inheritance of skeletal muscle insulin resistance. And we can, American Heart Association actually made a statement that really cardiovascular disease is not just a cardiac issue or vessel artery disease, it's actually a cardiometabolic disease. Now we can detect this fatty liver by using surrogate markers such as triglycerides to HDL ratio, an ALT is up, fasting insulin, fasting glucose, hemoglobin 1C, elevated uric acid. Now hepatologists can order FibroScan, which actually can non-invasively estimate both the fatty liver, but also the liver fibrosis. But I usually just ask my patients if they have a sweet tooth, and that will tell us where they're going. And we know insulin resistance has been associated with coronary disease, is actually the single most important amplifier for the LDL and VLDL and everything else. This was submitted to us in 1988 by Dr. Joel Raven, who was an endocrinologist at Stanford. He claimed, and he kind of disrupted the cardiology world, claiming that really cardiovascular disease, a majority of it is actually caused by insulin resistance. And when we are to look at insulin resistance, it seemed to be in charge of 67% of residual cardiovascular risk, even if we target the LDL to less than 70, whether we use high-intensity statin or we add PCSK9 inhibitor. And the main mechanism of that seemed to be through creation of oxidized LDL from triglyceride-rich remnant lipoproteins. And the best surrogate marker for that is actually triglycerides to HDL ratio. So insulin resistance does not necessarily cause disease just through glucose, which is advanced glycation products, but also and hyperglycemia. But most important is actually through hyperinsulinemia is a growth factor that causes progressive cardiovascular disease. So if I were to look into is the cardiovascular disease a progressive disease that starts as metabolic syndrome and goes through stages once you get fatty liver, pre-diabetes, and diabetes over 10, 20, 30 years, and eventually we get coronary disease in the relation to obesity. What it would be the purpose of semaglutide if we were to concomitantly lose weight and see if we can interrupt this process? And the way semaglutide, in the same way like Tirzepitide, both GLP-1 agonists work, at least for clinical perspective, there are two main mechanisms. They have a lot of a plethora of other mechanisms, but the two most important one is it blocks the appetite at the homeostatic center in the hypothalamus. Second, reduces the stomach, slows down the gastric emptying, and this way actually reduces the food absorption and reduces actually the insulin resistance. And there is, in at least particularly in obese patients, we know that their way their food intake is regulated is been different from the one who is lean. These are the three executive centers: homeostatic center and pleasure center of the regulator of food intake. And if you are obese or insulin resistant, the impact of fructose or polyunsaturated fatty acids on it is that it blocks your executive center. You don't know you're eating that, and then it just makes you hungry and hungrier. While if you're insulin sensitive, that does not happen. You just feel full and you stop. Stress and cortisol actually aggravates this through the amygdala. That's exactly the same thing. That's why we have the emotional stress eating. So the question is, GLP-1 receptor agonists, by blocking this homeostatic center, but also potentially working on the pleasure and sensation on the addiction part, can impact this. And we've known from prior studies that in order to, if you're obese and you have insulin resistance, if you lose 10%, anything you do that you lose 10% of your body weight, that actually starts to, which is about 22 pounds, that reverses not only the fatty liver, but also the insulin resistance. So there is the SELECT trial basically enrolled 17,000 patients, and the purpose was secondary prevention for coronary disease with morbid obesity. Most of you probably are familiar with this. The typical patient is 60 years old with history of morbid obesity. The BMI in average was actually 32 to 120 pounds, so not. There were very few patients that actually had a BMI higher than 35. Pre-diabetes and dyslipidemia, the exclusion criteria is hemoglobin 1C over 6.5, so they excluded the full-blown diabetics according to the HA guidelines. However, it turns out 66% had actually pre-diabetes. There were lipid lowering strategy with a target LDL around 78 on top of statin. And they had prior heart attack. And of course, the study was overwhelming positive. If you were to look at the absolute major adverse cardiac events risk reduction from a baseline of 8% placebo was down to 6.5, which means a 19% reduction. What I would say is, if I were to compare to our targeting the LDL actually below to the 30 or 50 in the PCSK9 inhibitor trials, that was actually equivalent or even more potent. But the body weight did drop on average by 9.4%. And now notice there's still a residual MACE risk about 80%. That was 8% of the patients were not, helped by it. The inflammation went down. Markers of fatty liver like triglyceride HDL ratio went down. But the single most remarkable thing that happened is when you look at these diabetics who had and they look at new onset type 2 diabetes, it dropped from 12% to 30%. And the pre-diabetes, there was up to 66% to begin the study. It dropped to about 21%. So if you were to look in a different way and say, well, this would have been a outcome by itself, actually the pre-diabetes necessary number to treat to prevent new onset diabetes, pre-diabetes was 1.3, and we prevent progression type 2 diabetes in 75% of the patient, and reverse pre-diabetes in 60% of the patient. So to me, it's probably, although coronary disease was the main product we look at, by the way, it did not change the mortality. The study were not designed for that. The single most important impact appears to be towards progression from pre-diabetes, diabetes, and reversal. And the question is, how does it work? Is it just through diabetes? What about fatty liver, which is supposed to be the first stage before type 2 diabetes? We have some study from Tirzepitide. And by the way, Tirzepitide works the same as Semaglutide, except also has a GIP, gastric inhibitor peptide analog function, which means also works straight on the adipose cell, fat cell, to cause increased lipoprotein lipase activity, and that burns the fat stores too. So I found actually often the patients will have fewer side effects with that, with the other might be more effective, although we don't know 100% that. But in this study that was with Tirzepatide in type 2 diabetics, they did an MRI version of it, and it showed that it actually does improve fatty liver compared to insulin, those patients who require insulin. So if I were to summarize this from cardiovascular perspective, you have a patient who had heart attack or peripheral vascular disease or stroke, and they're obese, and they have prediabetes. I give them semaglutide. They lose 10% of the weight, and I'm going to improve the coronary disease outcome by 20%. The mechanism appears to be by dropping the body weight, but the most significant impact seems to be on prevention of type 2 diabetes, but also reversing fatty liver and insulin resistance and triglycerides to HDL ratio. So in heart failure and in our nephrologists have a classification of chronic kidney disease progression, stage 1 to stage 5, the same we have in heart failure, A, B, C, D. Why? Because for each stage we have evidence-based medicine, a certain drug can interrupt the progression. Based on this study, actually, I'd like to propose that we could see, and again, this is not I'm not an endocrinologist, but this will be a cardiometabolic perspective disease. I think will help if we can think through and reclassify metabolic syndrome as stage 1 type 2 diabetes, which can progress to stage 2 diabetes once we have hemoglobin A1c is abnormal. And then the regular type 2 diabetes, we call it stage 3. Why? Because now we have evidence that if you give them a drug, particularly if they're obese in the stage 2, we can prevent the progression. But also the message to the patients when we tell them they have prediabetes, they say, well, I may or may not develop diabetes. They never really take us seriously to do something about it. Now, what about side effects for this? They're called, what they call in the studies, minor GI side effects. 20 to 50% have nausea, constipation, diarrhea. Now, I will tell you, for me, if I have to live with chronic nausea, that's not minor to me, but we'll just leave it like that. But this happens, maybe about 20% of patients are not able to tolerate them. It's much more rare. You can get gallbladder, disease, cholecystitis, pancreatitis, gastroparesis, bowel obstruction. These are quite rare, but they can lead to death. And now there are 2 meta-analyses that look at the incidence of these risk factors, and each of them, they looking different. One looking diabetics, one looking non-diabetic. So conclusion is that presence and duration of type 2 diabetes is the main risk factor for side effects. So if the patient has not gotten diabetes yet, full-blown diabetes, they're going to be more likely they're going to tolerate as opposed to the others. So keep that in mind. And also keep in mind that if once they stop the semaglutide or tirzepatide within 6 months, a lot of them will get back to normal disease, but also, and they'll regain their weight, but also 20-25% are non-responders. Careful with patients who are on hypoglycemic agents. I'm very shy starting that if somebody's on insulin or they're on glyburide. I think that requires a synchrony with an endocrinologist before you decide. I propose it, and then I'll ask them to discuss, but also talk to endocrinologists because they'll have to adjust the insulin accordingly. Now, a major issue that is going to become a problem, it's already a problem, is cost and disparity in the care affordability. HA estimated that the current Medicare budget, but also the whole U.S. healthcare cost for GLP-1 agonists, if you were to give it to everybody who deserves, will actually exceed this current Medicare and U.S. healthcare budget. So clearly we cannot afford that, no matter how we turn it around. And particularly for anesthesiologists or patients, we give them pre-op evaluation and clearance. Carefully, they're on semaglutide. There is increased risk of aspiration pneumonia for patients undergoing general anesthesia. I don't know exactly their guidelines rule. I assume that they have to stop for at least 1 or 2 weeks before. You also lose muscle too, and you can get sarcopenia long-term, particularly for women. While you may improve obesity, you may have an increased risk of falls later on, which we know women, and it's a major problem. It's still debate about the risk of suicidal ideation. Once upon a time, rimonabant is a drug that was used for obesity, blocks the cannabinoid receptor. Basically, it's anti-marijuana receptor. Was approved, improved cardiovascular outcome. It was Ozempic before Ozempic in 2003 came out, was approved. 2006, they had to take it out of the market because increased suicidal ideation, because although off-target effects of blocking something that's important for the food intake will also block the dopamine release in the pleasure center, and people who have prior major depression will be suicidal. But what I'm more excited about is for the future. We have 4 trials there. Hopefully we'll soon have results. One is basically Tirzepitide, for the same like SELECT trial, but for Tirzepitide. Then we have the same studies, but for type 2 diabetics, both semaglutide and Tirzepitide. But what's really close to my heart is I want to see what Tirzepitide does for heart failure with preserved ejection fraction, because I believe the HFpEF, it's a cardiometabolic disease. The heart is just an innocent bystander part of it that becomes sucked into it, but probably the biggest impact we can have if we can work on that. Basically, they're wanted to point out that Ozempic and Mounjaro, doesn't matter how we turn it around, they buy us time. It's like a Band-Aid, doesn't fix the cause, which is the ultra-processed food intake. As a matter of fact, the number one, in my experience, the number one cause of a failure in the obesity treatment with Ozempic or Tirzepatide is actually no change in their diet. And that can happen. And, food companies went through food scares with various theories we had on food, and, public reacted to it. Really, they were shocked with the only one that really made impact was the Atkins diet, which is a keto diet. And unfortunately, he died on a skating accident. After that, they came back. Now we went through gluten, dairy scare. And I was hoping that 2020's decade will be hey, let's talk about ultra-processed food and cut the sugars and vegetables in our diet. Of course, that's not going to happen because now we got Ozempic and Wegovy and Mounjaro. You can just skip all that, eat all you want, and you're going to have solve the issues. No, we're not solving the issue. And yes, food companies are adapting. They already come up with new products. Nestle is launching a whole line for people who are on Ozempic. And remember that although we concentrate on obesity, there's also things outside, fat inside, which actually are 9 times more likely in the last 5 years to, if you get fatty liver and your weight may not go up because your BMI is less than 25, you actually still can get insulin resistance and coronary disease from that. So at the end, the way I created this 80-20, the Pareto principle for cardiovascular disease. See, we eat ultra-processed food, and you can, depending on your genetic predisposition, you can go straight to obesity because your actually adipose cells can accumulate fat and actually protects you from fatty liver for a while, up to about 22 pounds gain. After that, you start to have fatty liver. While if you don't have predisposition for obesity and your fat cannot accommodate, you actually can be thin outside, fatty side. The fat goes straight into the liver, and you get much sooner disease. So ultra-processed food is designed to stimulate our dopamine reward center. It changes our behavior, increases our brain intake of everything. It's 80% of disease that's caused that. With GLP-1 receptor agonists, bariatric surgery, keto diets, you name it, or vegan diet, you can try to impact that by reducing that. And you do, GLP-1 receptor antagonist have a good impact on that. The problem is that 80%, while that is in charge of 80% of the intake of the food, 80% of disease is caused by the ultra-processed. So if we don't change this, although we may lose some weight, we're still going to be sick. And what you eat, it matters. The rest is epigenetic and stress and sleep regulation. So the first thing I'd ask my patients is that, you got to eat home cooked foods, buy the real ingredients, cook. That's very important. You got to cut the ultra processed because that's not food, at least not where our mitochondria think. And then we talk about the healthy lifestyle changes. This is the last slide. I'm going to stop here. But I want to make and I know I have a lot of important points, but this is actually essential because nothing works unless we understand for a given patient what makes the difference to get them to be able to change. So when we talk about lifestyles, look at this. We have plenty of things. You can work on food, exercise, sleep. Which one do you think is the single most important that makes difference for everything else? And the answer is stress. All right. This is the single most influential book I've ever read in my life. I highly encourage everybody to read it. And this is evidence-based medicine. This is not popular science. And he quotes, Gabor Mate quotes Tony Blair when he left the office. He said, many health problems are not strictly speaking public health problems at all. They're questions of lifestyle, obesity, smoking, alcohol abuse, diabetes. These are not epidemics in the epidemiological sense. They are the results of individual decisions at million points in time. All right. Trying being a politician, he shifted the public office blame towards individual blame. And actually, we have a lot of evidence showing that chronic stress is the one that determines the lifestyle and not the other one. Before we see the world creates us and how we see the world. And it's not really it's not what you're eating, but it's what's eating you that makes a difference. So we can change the lifestyle. And we know this long time ago, since 98, Dr. Felitti, who did a study with Kaiser Permanente, they look at the relationship of childhood abuse and household dysfunction to the so-called adverse childhood experience study. And everybody knows how impactful they are in our life for any chronic diseases. But guess what? The way he found about this, he was studying obesity. He had a bariatric clinic. He was helping patients to lose weight. So he will work hard with them for about 2 or 3 years. They will lose 5% of their body weight. Then within 3 months, they'll go back in. And then he started to ask them about who they were, what happened. And this is how he learned the number one cause of why obesity failure treatment failed was because it was in those with advanced cardiovascular events. American Heart Association now separates this ACE into also adverse community environments. And I'm going to stop here. But we really need a revolution how we feed ourselves, our children, our students, how we feed our patients in the hospital and how our senior care centers feed their residents. All right.
Okay, thank you so much, Dan. That was fantastic and a very unique presentation. I know it must have taken you hours to put together that. It ties in a lot of mechanisms and presenting a unifying hypothesis with mitochondrial dysfunction and cardiometabolic risk, and then what we can do, some practical things for our patients. In the interest of time, it is 8:40. I know a lot of people have had to sign off. Are there any questions for Dan? Maybe we can take one question. If anybody has a question or a comment, go ahead and unmute or type it into the chat. I think, Dan, probably people do have a lot of questions. They're probably going to contact you individually.
Yeah.
Just given the time. But thank you again so much. This was, it ties in with your part 1, 2, and 3. I know there was a lot in the third section here.
Well, that's why we recorded, so people are interested, they can go back. But also, I actually have a more detail, and for those who are interested, presentation that we recorded here at Midtown, and we posted on the Rescue Heart Failure Lecture channel, how to get healthy and live long without Ozempic, for those who are interested. So, all right.
Is that for patients or for?
This is the only lecture I put together for both patients and healthcare professionals. And I've noticed this, I get the equivalent lecture for doctors last year and for patients in November. And I can't, when I look at how many views on the doctor's versions, like 200, 300, I have 3,000 on the patient side. So I notice I can't really get the doctors to pay attention to anything about nutrition education unless I put some drug name in the title. That's why I put that there. Obviously, I was not able to fool everybody around. I had to talk about Ozempic, but I don't think really that's the issue. The issue is we're not really, the food research that has been done in the last 15 years is not being incorporated in the guidelines. It's been totally ignored. It actually totally contradicts everything we've known for 50 years from the guidelines. And doctors and us, we need to be educated. We owe that to our patients. We owe it to us and to our family. And that's what I'm trying to put here together.
Great. Thank you. Thank you so much again. And thank you everyone for joining. Don't forget your CME credit, and I'll see you next week. Thank you.
The preceding program is copyrighted by Emory University.